Hey, it's Dr. Jelani. All right, so today we're going to talk about remote patient monitoring, chronic care management. What is it? Why you need it? Who needs it? Who pays for it? So, this is a program that Medicare started and they implemented. The basic premise is you get to bring a little bit of peace of the hospital home. You get your vitals monitored. You check them. Your blood pressure cuff is connected to a Bluetooth, and it goes to a software, and it's transmitted. So Medicare pays about roughly $45 for the transmission of this data, but they're pretty sneaky in the fact that they'll only pay the physician if the customer or the Medicare patient does it at least 16 times a month. So if you do it 15 times a month, which is every other day, it's pretty good, I would say, but Medicare won't pay. The doctor is going to manage whatever comes about from it. Now, hypertension is just one thing that you can catch from your vitals, but honestly, there is a slew of things that can result from it. There's a lot of things that can be ascertained from it too. So let's take, for example, you're a COPD patient that's been on prednisone off and on for exacerbations in your life, and you're not on it quite right now, but it shows that your trend is going lower. So it's not like, oh, okay, let's just make sure that you're not on any blood pressure medications. It could unsurface that you have an adrenal insufficiency or a relative adrenal insufficiency. So there's a way to take care of this, and it portends other things, like say you have an infection and then your blood pressure drops a lot, then you might need some stress dose steroids. It might land you into the hospital, but what if you just have the flu and it's not that big of a problem, but because your blood pressure dropped, you feel really woozy, dizzy, maybe you even hit yourself, but you didn't prepare for it. You got the prodrome of symptoms for the influenza, but you didn't get that stress dose steroid, which could have prevented you going from the hospital. So those are things like multi-steps ahead from what looking at these trends could decipher. Now, this is chronic care management. It's not acute care management. So there is a limitation in that it's not really your doctor on speed dial. However, it can still be a massive benefit. It is a massive benefit to each and every individual over a course of time. You may not see the benefit in the first few months. You may see benefit immediately. Adjusting your medications is something that happens slow over as an outpatient and is done with limited data. So say for example, I have a patient in the hospital. I have them for 3 to 4 days. We get labs we get vitals maybe eight times a day over the course of 3 days. So I have 24 vitals, as opposed to outpatient. You'll see them once every 6 months, maybe once every 12 months. They'll do one set of vitals, maybe two at most, but they're just really they're back to back. There isn't any time separation for them. So and then let's say you move on to acute rehab an Encompass, which I work at as well. So we would take vitals on average say 5 times a day for about a couple weeks, and we basically get 60 vitals. So we can see there's variations. You'd be surprised that blood pressures can be anywhere from 80s to 160s in the same person within the span of 2 weeks. So how do you manage that? Well, each person is individual, has their individual issues and their unique issues. So in the outpatient setting, it's kind of okay, here's your drug, you go take it, day and night. But maybe you don't need it in the morning, you really need it in the afternoon. I mean, these things cannot be deciphered as an outpatient. This makes this thing so valuable that over time you can individualize, fine-tuning medications. Another thing is that usually this chronic care management is for 2 chronic conditions. and for more so for the elderly population, because you don't really need very brutal monitoring in your 40s, probably not even in your 50s. But once you start getting your 60s, 70s, 80s, this starts to be more and more valuable. After you have a stroke, a lot of people have their first stroke in their 60s. This starts to become a necessity. Now, a lot of people are just checking their blood pressure at home by themselves, but that's not really a good documentation. So at the very base level, remote monitoring and chronic care management is like having a documentation of your blood pressure over time and can show trends. I'm not sure that it will actually provide a benefit for this, but I could portend that maybe a life insurance company would be like, hey, your blood pressure has been amazing, and you could prove it with your remote patient monitoring that's been great for 2 years. Maybe they could decrease your cost for your life insurance even after you have a stroke, something like that, because it's proof. Now, is you taking it home and writing chicken scratch on your notebook, is that the same amount of proof? Probably not, right? So I think it's very beneficial to be on this for the people that need it. I tend to handpick more sicker patients because they need it, right? And I can provide a lot of benefit there, especially coming from the hospital setting. I see things that outpatient doctors necessarily will not see. And I think of course, in my back of my mind, more serious issues. So I like this a lot for the patients that I order it for. And sometimes they can't see how beneficial it is, but over time, I think everyone that's on it would definitely see how amazing this is, and how if this is something that you're suggested to need, you need it. Now, there is companies that do this where they kind of link up with the doctor and be like, if you have a couple chronic conditions, then put them on it. But are those the ones that really need it? I mean, maybe not. I'm the type of person that I understand how much foundation goes into medicine, that you can Google stuff, and you could be a PA, you could be an NP, but you don't really know what's going on. Like you can't think about everything all the time. So I think that it's really not on the same playing field, even though that won't come across necessarily, except to the very well educated. You have to understand that, forget nurses, clinical staff, PA, and NP, there's different levels, even in doctors. Some graduate top of their class, some barely squeak by, some fail, some don't pass their boards, some go to, there's I would say schools are kind of tiered into about 3 categories, especially for fellowships. So internal medicine isn't a fellowship, but there are fellowships afterwards. But even I wanted to do radiation oncology, and I did a lot of research throughout my life, but there was a certain type of oncology that I wanted to do that was really only up for grabs for the top third of the oncology programs, because the top third were hyper specialized on one thing, and they're the expert at that, and they do all their research on that. In the middle tier, they kind of do a little bit of everything, and they're really smart. And then the bottom tier, they're very community driven and focused. So I never saw myself as just kind of the catch-all. I always see myself kind of very hyper focused on one thing and just being the best at that. I'll tell you, when I took my boards, I did excellently, but I didn't know GYN. It's in medicine you have to know about everything, but I mean, there's just some things like, I enjoy pediatrics a lot. I knew it pretty well. But like something, a psych, like I knew it extremely well at the time. But like GYN, I had no interest in. It was just kind of in one ear, out the other. I wasn't really focused on it. But there are certain things that I like really focused on. And I think like that's kind of how I've always been, like just very focused on what I want to be the best at, right? I mean, I don't feel like you could be the best at too many different things. You can be best at few things. Even like when I give you a very good example. My mother, she had lymphoma for many years, but most recently she degenerated into having a very rare T-cell CNS lymphoma. So she's a Kaiser patient. They never saw this ever. They had B-cell CNS lymphoma sporadically, rarely, but they never saw a T-cell CNS lymphoma. So of course, we try to link her to a lymphoma specialist. We picked a guy at UCLA. He was amazing. Dr. Erdat was his name. I think I think specialty in medicine is even in niche circumstances is very valuable. We also use like some people from Harvard and ask them questions just to double check what they were doing at Kaiser, because Kaiser is very community driven. They're very good at population medicine, but like when there's something very rare, I mean, it's something that it's not that they're not good at, they haven't seen it. So and I was fortunate enough where I practiced in Silicon Valley. I practiced at a hospital where there was a lot of Stanford doctors, UCSF doctors, and UCSF happens to be a primary CNS lymphoma center. So I got to talk to my colleagues about something that my mother had that was very rare. Now, that's a very, very like extreme example. But even like my wife's endocrinologist, he doesn't actually, really do much of regular endocrinology. He just hyper focuses on diabetes, and he's really good at it. My wife loves him. But even I was trying to tell him, hey, I think you should check for testosterone. I think my wife has some issues. He didn't know where to begin, so I had to kind of walk him through checking the cortisol at night, the DHEAS, and checking testosterone levels, and really like how it was actually secondary by peripheral fat conversion. This comes from like a mastery of internal medicine. So the reason that I like, and I'm right now that I'm focused on this remote patient monitoring, because I think it's scalable. I think it brings the peace of the hospital home, and I love that, because I love hospital medicine, and I feel like I could diagnose things even remotely that a lot of people would miss just by keeping tabs on you. So whether you have AFib, CHF, COPD, or some have all the above at the same time with hypertension and hypotension, tachycardia and bradycardia, sick sinus syndrome all at the same time, this kind of monitoring and trend gathering can really change a person's life with the right person behind it, and the right team behind it. So I often get, I guess my purpose of getting into outpatient medicine was that I lose sight with all these people that I grow to like. I want to have connections with in the hospital. Some even ask me, hey, I'd like you to be my primary care, but being a primary care means having an office, having electricity to turn on, or at least office staff, a scheduling staff, a commitment with a lab group, and it takes time to set up. And I wanted to do something where I can make a big impact, but not have to deal with so much the overhead and headache. So, that's how I really came to pick this. And I think with the way that AI is coming about, and tech, and how I've always had, maybe for the last 7 years, like a mind for algorithms, a mind for systems-based management. I feel that I could put that together in this type of company, and that's why I'm really excited about this. I think I'm gonna blow it out of the water. I think I'm going to do things that people have never heard of. I've decided to create my own EMR. I didn't want to rely on another manufacturer's software or a distributor's software. So I started off by working on my own EMR, and I feel like this EMR is going to be a gateway to creating this master EMR that I have aspirations to. So I love Cerner. That's my favorite EMR. Oracle recently bought it a few years ago. It's black and white, but it functions perfectly and just gives speed to the doctor. Now, it's still a bit of a glorified pen and paper, so I think that there's a lot that can be built on top of it. I think Epic is widely considered the best one, and Cerner is like a close second place. Although in my opinion, Cerner is better, and I work with it better because it's just a lot faster. Epic has this small element of gamification to it, and I think that's where most software kind of is leading towards, making it a little colorful, playful, a little bit gamified. However, I feel that it doesn't really give me enough benefit for the extra time I'm spending getting through it. So I don't find that Epic is the best. So and I still feel like it's a bit of a glorified pen and paper. Electronically sending stuff, very, very helpful nonetheless. But where I'm trying to get at with this is, I want to build this master EMR system that all hospitals are going to use, and it will bring Harvard style or Harvard quality medicine, or just top tier quality medicine, to every hospital. What I've come across in this decade long of doing hospitalist medicine is that there's a lot of hospitals that don't have good access to care. There's some have very difficult, getting strong hospitalists. And this need has grown to the point where a lot of the smart minds flock to more specialties, and this leads to getting more foreign doctors and opening up for foreign grads, getting foreign internal medicine doctors doing residency here. Of course, a lot of them get a chance, if not all of them most of them get a chance to do internal medicine here, and a lot of smart people around the world can come here and soak up these jobs, right? But they're definitely not met by the Americans that are going into medicine. I can tell you, I went to UC Berkeley. I finished my coursework in 3 years. I think we had like 1,000 pre-med doctors, which was an amazing amount. But like, just the way that UC Berkeley is designed, as it was always ranked number one as the public school, and maybe top 10, top 11, pretty much. I'm not sure what the ranking is now, but for the entirety of its life. So the way these top-notch schools are designed, they try to weed their students out. So especially with the more competitive majors like electrical engineering, computer science, bioengineering, molecular cell biology, and basically pre-med, and business big Haas Business School. I remember I was doing bioengineering and business, and I changed to molecular cell biology, and I was still doing the most of the work for the business second degree, but I finished a year early. I let go of the business degree, and I just focused on doing research. And I was getting homesick at that time. My mom was initially diagnosed with cancer at that time, so I was getting homesick and depressed in Berkeley. So I started doing research at UCLA, and I was there for a few years. I spent a lot of time doing that, and not going into oncology or radiation oncology. I think was very pivotal, but there comes a time in your life where you have to make a decision with your wife, and at that time the kids that I thought I was going to have, which I have now, about where you want to take the direction of your life. I mean, honestly, I went into medicine to be a neurosurgeon. I didn't really want to focus on anything but the brain. That's it. I really didn't think anything else was worth it. I just wanted to be the head honcho of the hospital. I wanted to be a neurosurgeon. I started at Berkeley. Somebody gave me a chance to work at Stanford, following some of the fourth or fifth year residents. I got that chance. It was pretty cutthroat. I followed a lot of neurosurgeons between New York, Marin General Hospital up north. Beautiful place, very low key, a very wealthy place. And the one thing that I loved is that it was absolutely everything I wanted to do, but at the same time it gave me no family lifestyle. My neurosurgeons, two of them, of the five that I knew, two of them treated me like their son, and they didn't even know their own son. One of them didn't know his own son. I think that's the thing that really stuck out to me, is that one of them didn't know his own son, didn't spend time with him, wasn't close to him. And I was like, wow, you love your career, but yet to be distanced from your family and your religion, I feel like that's the point where you cross the line. Many years later, people was like, yeah, you could still do neurosurgery, you could just do it on your own time, do a lot less. But I don't know, I'm just not of that mindset where you could be good, or dabble, or be kind of good, or very good. I feel like it's either you be great at what you do and you love it, or do the thing that you really love, because there's a big difference when you're doing something that you love. I don't know how I came into hospitalist medicine. It was kind of like a filler thing for me to go into oncology, get my debt down. I had a lot of debt. We didn't grow up with a lot of money. Contrast to that, my grandpa was getting extremely wealthy in his country. He was worth a lot of money, but me and my mom and dad, we were we're just getting by. I think we were like lower middle class at that time, just getting by. But I always knew in the back of my mind I would make it, and it was just time until I get there. So what does this mean about chronic care management? I mean, I just fell into love this. I have new passions in my life now, which include like blockchain, AI, automation. I wasn't necessarily like in love with AI specifically. I am with blockchain and automation, but AI is pretty much, automation. That's really what it is. So it's nice that you could program the automation within an AI context, and it actually makes it simpler. For like the last 6 years, I've been trying to create. I've had in the back of my mind to create this EMR system that would basically run a hospital system. And I even talked to like patients in El Camino that were like, they were working at Google. I remember I had one patient, his Chinese patient, they were actually working on healthcare software, and they're like, and I was telling him, like, I've been to a lot of hospitals, and there's just some nuances that I can't see you guys would ever pick up, no matter who you talk to. Like, I think it's really for a very small set of people that can actually pull this off, from a legality point of view, from an execution point of view. And you would have to have like tech in the back of your mind the whole time. It's not just something like you could sit down with a doctor and just ask him questions. I mean, you wouldn't even know what to ask, because you've not, there's differences between how hospitals operate, and how they undergo the standard of care. And that can be due to various of reasons. It could be due to a monetary reason. It could be due to access to resources, and those resources could be both technical or skilled expertise. Like, maybe they don't have the right type of doctor, or maybe they don't have the certain diagnostic testing, or maybe their doctors are trained on a community level but don't have that academic kind of foundation. And maybe even that academic foundation is just not appropriate. Like, I worked at a hospital in Bakersfield Memorial. It's not an academic hospital, so I felt there was just a lot of things that I couldn't even dive into, right? And I've worked at like UCLA. I mean, you could, at West Hills, you could deep dive into like whatever you want, even West Hills, there was a little bit of limitation because it wasn't like UCLA Westwood, so they didn't actually have access to everything in a timeliness fashion. They had access to everything, but not in a timely fashion. So you're always working against the clock in a hospital setting. The hospital has this expectation for you to be efficient with your care, and you're kind of, as a hospital, groomed to be very efficient with the length of time that you have a patient in the hospital. Most patients understand that. A very small few think it's egregious that we don't keep them there until they're 100% better. But we always have to like delineate, hey, is this something that can be managed as an inpatient or outpatient? Obviously, insurance paying the hospital plays a big role for the hospital, so they force us to consider that, and it's not necessarily a bad thing, because you have to have the personnel to really deliver appropriate care. So I think this also goes back to like, this EMR system that I wanted to create, and how the appropriate care has a different definition in each local area and each hospital. So I think, doing this chronic care management and remote patient monitoring, I think someone that can be a patient within the context of the knowledge base that I have blessed from God, thank you, is absolutely an amazing thing for a patient to have. I'm really passionate about it right now. I think there's a lot of things that will come about it. I think just from my EMR system, I think I'm going to oracleize and blockchain data when this scales. And that can be game changing for hospitals to have proper information on patients. I can tell you, even a discharge from a hospital to like an acute rehab setting, it's strange how like medications get missed. I mean, yeah, medications get missed from home to the hospital setting, but from the hospital setting to acute rehab, I mean, usually, typically, the rehab doctor is the primary, so they do the admission orders and reconcile the meds. But it's just strange that even things get missed. So I think building a centralized database is where my ultimate goal is going to be from doing this. And I think that could change, not just a centralized database, but a centralized EMR with a centralized database that can blockchain oracleize data to other hospitals is something that I think I can already create, and I just need to get to the masses. So I think this is the right way. I don't have any means to step over your cardiologist or your primary care physician. I act as this company, this method of management is meant to be a glue between visits. It's meant to enrich your cardiologist with the right data to take things away, like adjusting medications or leave it up to them completely, but give them the proper data for it. Refill medications and just take a big load off. Be a sigh of relief for the primary care physician, possibly the pulmonologist, and even the cardiologist that you may have that's working with you. And then you can access the data and provide it to them. So this is a great thing. We will accept enrollment. There's a Medicare and a non-Medicare fee. Medicare is pretty much free month to month. We don't charge anything for Medicare patients except for the setup fee. Medicare, I think, reimburses like $19, which doesn't even cover the shipping. It doesn't cover the time, resources, EMR, or the device. So we have a small setup fee. But other than that, for Medicare, it's free. There is a cash pay option for those that are abroad. I got a good story there. So I think I told you that my grandparents were very wealthy. I think after my parents moved to America, before I was born here, my dad's older brother already settled here, so he came. They did everything the right way, got a green card, there had been citizens for maybe, 25, 30 years, maybe more. They did everything, the right way, no shortcuts. I was born here. I was born Ohio actually. Where was I going with this? My grandparents are actually very, very wealthy. But they started their ascent like a little bit after my parents moved here. So in their country, even getting something like a thoracentesis, which is like putting a needle in your lung, just draining some fluids, it's like nothing here. They need to Airbus themselves to a medical hub like Singapore, which that plane flight alone costs like around $100,000 just to get a thoracentesis. I mean, it's kind of sad and ridiculous. So, there's usually like servants, I guess, in these countries like Bangladesh, India, perhaps even Pakistan. I think, Pakistan as well. I've been to Pakistan. I think they have servants there too. A lot of this like home caretaking is on the, let's call them like kind of analogous to a CNA, right? So even for someone like that, I think this would be a tremendous upgrade. So I can see this being international. a tremendous upgrade. This could, I mean, this is not limited to people of low socioeconomic standing. I think even an Arab prince from Dubai could vastly benefit from this. Of course, they would probably want more of a full concierge package, which we want to offer. We want to offer for royalty, for larger name celebrities, the ones that really need not just good care, but you want to rely on us to transform your life and keep you at your best, not thinking about it. You know, maybe fly to you, just get really I mean, money moves things, you know that. There's this saying that, like, it's not that you're not pretty, but you just don't have enough money. I mean, I think it's pretty funny. I don't know if I'm really of that mindset, but I think you be natural and, you know, you do the right things, eat the right stuff. And I think for males it's easier than females. I mean, you could just hit up the gym and make yourself better looking, you know, by doing the right things, you know. I mean, even if like you don't grow up that good looking, and say you're a male, you go hit up the gym, you got muscles everywhere. I mean, it looks good. You got muscles on your face, muscles on your body, you're lean. It transforms your outward appearance. It gives you confidence. And for males, you know, I mean, let me speak for males. Like, you know, your confidence comes from, you know, things that you're a master at, things that you're extremely good at. It gives you confidence, and your body, you know, you're taking care of your body. Like, I don't smoke, I don't drink. Allahu Alam, I try to be a good person. So sign up for this thing. It's good for you. But let us do an intake and see if that you're the right type of person for this thing. Don't matter if you're domestic or international. I mean, cash pays nothing. My grandpa's not alive. He'd probably pay 10 times as much for the thing that I'm offering for free for Medicare, and without a sweat. He died actually of a sudden cardiac arrest. I'm sure, you know, he's running 31 branches. He was Fortune 1 in IT in his division. I mean, who knows? His blood pressure was probably sky high. Nobody was checking it, you know. Maybe his heart rate is going up. His family was stressing him out all the time. He had like two daughters and 2 sons. Some of the business got split. My mom's younger brother, he became really big. He's still really big. I think he even owns a cricket team in Bangladesh now. He owns a bunch of telecommunications. He's big. He's big there. I think he even owns Miss Universe. I don't know how, or for the Bangladesh version. So they're smart. They're smart people. I think they even have they do a lot of the wires for the telecommunications over there. And then I think my mom's older brother, he used to do with my grandfather, used to do all the big government contracts. So like the big government contracts that they were doing, IT in like some of the prominent Indian hospitals that were near Bangladesh in India. But their focus was software and banking. just bringing that wave over at that time where the internet was new. Now there's a lot of waves going on now. AI, blockchain, and it's an exciting and very anxious time to be alive right now. Things are moving very, very fast. Robotics is coming. And I feel like all this will incorporate into healthcare with the right minds. I want to be a part of it. I want to be a part of it, and I want to start here. I want to bring very good value care to you guys. I want you guys to be happy. And I was alluding to earlier that this is more for older population. When I was at Wayne State, we were doing a geriatric rotation at I think on the main campus in Detroit. I'm forgetting the name. It's not Henry Ford. It's Wayne State, but it's there's a couple different campuses there on the Detroit side. We did I'd say maybe half of our specialty rotations on the Wayne State campus while we're doing residency at Wayne State. But in this geriatric rotation, the thing that really stuck out was this polypharmacy. Being on a lot of medications, being on a lot of having a lot of side effects. Gradually got to tone down on these medications that were helping you in your 60s and 70s, but in your 80s, 90s are deleterious to your health. So this is a hidden benefit of this, that we can look at a trend and in seconds at least decipher, hey, you know what, we can start toning down some of these meds. I think you're needing it less and less. Did you know that, let's remove that the patient has CHF, doesn't have CHF, so the parameters are different, but say the patient doesn't have CHF and is 80 years old. The new set point for blood pressure is systolic of 140, where for the regular population it's 120, right? And the reason is because over 80 years of life, you've developed some plaque. Your arteries are not the same, and you need that increased blood pressure to perfuse your brain. So a lot of the times, we're focused on getting that blood pressure down, getting it low enough. We accept the fact that your blood pressure is below 120 because that target is 120, but there comes a point in people's lives where that's not the ideal target anymore. I remember when I was a teenager, my I would say really when I was 18, because 18 is when I started working out hardcore, going to the gym 3.5 hours, 3 times a week, just circuit training like a madman. My set blood pressure was in the 90s. So obviously I was healthy. That wasn't hypotensive. That was my resting blood pressure, because probably my blood pressure was sky high when I was working out to match the weights that I was lifting. I really need to get back into the gym. I love it. I just wish I had more time. But it's relative, so you could be in your 70s, and then as we get into your 80s, we're slowly dropping things off before they become a problem. I can tell you in the hospital, it's kind of always after the fact. Somebody comes in with, oh my God, too many blood pressure medications. What the hell was the primary care doing? Patient had a fall, broke his hip, comes for a femur fracture, we're fixing his hip, we find out his blood pressure medications are just way too high. But really, is it the primary care physician's fault? No. Silently behind closed doors, this elderly gentleman, his blood pressure has been slowly needing to be higher and higher to keep up with the demand of his brain, and to overcome, the resistance that the arteries can cause from plaque, from older age. And high blood pressure is a problem too. Obviously, it leads to hypertension, stroke, MIs. MIs are like heart attacks. So it's that fine delineation, you can't always get it right. Some people kind of have that catch-22 going on where you can't be too high, you can't be too low. They have a DVT, or they have a clot basically, and they have like a bleeding problem, maybe a bleed in the brain, maybe a bleed in the GI tract, like an ulcer or something. So sometimes some people have gone to the point where you got to catch 22. You got to pick one, and the other is a problem, and there's really no way around it. So these kinds of things, like chronic care management, daily checking your vitals, can fine tune it very, very, very minutely over a course of time, and hopefully improve the value of your care. I thank you guys so much for listening to this. This is Dr. Sheikhul Jilani. Please like the video. Please be free to express interest, and let us take care of you. All right? Let us be a beacon of your health. Let us be the glue between your visits, and I think you'll really like it tremendously. Thank you so much. Okay, guys, take care until the next one. Bye.